Okay, it is the magical hour of 4 o'clock. Are we ready? You coming up here now? Oh, great. Okay, thank you so much for coming, and I am so honored to be here. This is actually my fourth conference. The first two were virtual, and how happy are we to be in person for the second year? I want to introduce Georgianna, as we call her Gigi Thomas. She is part of our OT team, and then we have Dayle, and she's been with us a couple of years, and we have Dayle Federico, one of our wonderful PTs, who's been with us since 2013, so many years now, and I'm blessed to have them on the team. They are integral to every single thing we do, and especially to treating our kids and families with arthrogryposis. That said, sorry. Okay. Um, let's make sure I know how to. There we go. We're going to talk about a variety of things today, but first we're going to begin with early intervention. And we love to get kids early and start the process early. Many of our children we know are going to need surgeries as they get older, but it's always a good idea to get as much motion as you can in the beginning. They've got a window of opportunity to get some mobility, and sometimes the surgical interventions that they need are less if you've had good early intervention. So babies tend to be affected throughout their bodies at birth. I'm going to sail through some of this stuff because I think that all speakers are saying a lot of the same things. As we know, trunk, spine, upper and lower extremities are often involved. I've heard of many centers that say wait and see. Many families that end up coming to us have been told wait and see what happens. And that's not always a great option. We don't believe particularly in that option. Our strategy is to get them moving as early as possible. We call it unlocking them because when their tissue is so tight and so rigid and their muscles are weak, that is not a good combination for movement. And our overall philosophy is do no harm. So we look at the interventions that we're going to use. What can we use that will do no harm but can get them moving? So we believe that early intervention is key. Physical therapy, occupational therapy, we both use in physical and occupational. We use serial casting and serial splinting. Serial meaning repeated to gain more motion with each one. And then once they have achieved either a plateau or correction, we do bracing to hold that correction. And then we do modalities to stimulate movement, movement, movement. These are some of our kids pre-intervention. You'll see these kids recurring throughout this today. And our families have given us permission to use their photos, and they are fine with this using their names. I always feel strange doing that because, with HIPAA and everything, but they're very proud to be on here. So in the beginning, we do an assessment. Typically before they come to us, they've either seen Dr. Feldman or one of the other doctors at our center. However, sometimes the doctors will say, please go see therapy first, and they'll read our report and get a background. So PT and OT often assess together, or sometimes we do it separately if we don't have a schedule that will mesh that day. We look at the developmental positions, their postures, what postures are they in? We look at all the normal things you would look at in PT, supine prone, supported sit, supported stand, and functional mobility. How is that child moving? What's appropriate for their age and how on the spectrum are they as far as their movement? We look at the active and the passive range of motion and strength, head control, trunk control, upper and lower extremities, and daily living skills appropriate for that age. If it's an infant, are they able to suck and swallow? Are they able to roll? Are they able to hold their head up? Are they able, if they're bottle fed, to hold the bottle? And we look at the family's goals and concerns, or the child's if they're old enough to voice that. We use what we call a multimodal approach, where we want to address the soft tissue preparation with things such as moist heat. ASTEM is a soft tissue tool that helps to make the soft tissue and muscle and tendon and fascia more pliable through a variety of mechanisms. We use massage, myofascial release, cupping, paraffin. We take our toolbox and we use whatever tool we think is going to be most effective. We use manual techniques, gentle and progressive passive range of motion, and then we use as needed joint mobilization or joint distraction by gently pulling the joint apart gently to get a little bit of space to create some movement. We use multiple and progressive prolonged stretches to include posterior casting and splinting is part of that. I'm going to let Gigi take this one.
So these are a couple of examples of the ASTEM, the soft tissue release. We also do Coban, kinesiotaping, cupping, paraffin, which is one of my favorites, almost as if it's we use it. We do Coban to kind of promote the passive stretch. Then we do the paraffin dipping and we wrap it. We let it sit for like 15 minutes and it really opens up the muscles and helps us with flexibility. Then we'll follow that with passive stretching. So after we kind of open them up, we try to get more active movement. We do active range of motion. We use electrical stimulation. We use active assisted range of motion, self range of motion. We change positions. We like to use gravity eliminated positions to kind of allow the muscles to do what they can do. And then we also love to use kinesiotape and Coban to kind of hold those positions that we've gained.
So with the multimodal approach, we want to make sure that we're hitting developmental milestones to the ability of the patient. So we work on rolling, sitting with support, coming to sit. We work on independent sit and reaching in all positions, grasp, release, midline play, weight bearing through the upper extremities. And I want to say that, but also, if a child gets stuck and is not meeting a milestone, we don't freeze their treatment there like, well, they're not sitting independently, so we can't work on standing. We don't believe that. We do believe that you can kind of, you meet the child where they're at, and even standing can help with trunk control. So and maybe that's supported standing in a light gait or some type of device, but we work on fluidity through their abilities and motion.
So here we talk about the developmental milestones, starting in quadruped with support, whether or not they could be in quadruped with or without support. We'll work on weight shifting. We'll also work on standing with the braces, with or without the braces, with electrical stimulation or without. We're kind of just working with what we can, and our goal is always to do no harm, but opening up the child, seeing what they could do. We work with, in PT with walking on the light gate, whether on a treadmill or just walking to play to get active motion. And with fine motor control, we also use Coban, that anti-gravity positions, working on intrinsic hand function and elbow and shoulder movements.
So how do we achieve motion? You must have passive motion before you'll have active motion. Just think about that for a second. If we can access motion in a joint, it cannot be accessed actively, right? So we want to make sure that we're getting at least the passive range of motion, and then we don't know initially if that child's going to have the muscles to move that or the muscle strength, but we do not assume anything. We work towards it, and we assume that all muscles are there until proven differently. So we're going to try and facilitate that with all the modalities that we've just talked about. As all of the speakers here have talked about, different body parts are affected. We know that the trunk and spine can be affected, scoliosis, kyphosis, contractures, stiffness, and almost every infant born with arthrogryposis has some level of torticollis. So we address those as we're addressing the whole child. When we're addressing the feet, we correct the feet first if the knees are flexed, and we do so with Ponseti casting, just like Dr. Nichols was talking about there, and vertical talus, the reverse Ponseti. When we have them in casts, we also are addressing hips. So many of the babies are stuck in abduction, external rotation, and knee flexion. So we've got this child here. See that she has a little strap holding her legs together. Her legs were stuck in abduction. Some children are so stuck that their hips anteriorly dislocate. And so we start moving those and elongating the posterior muscles and the abductors in day one in cast, and we teach that to the parents. And then we put this strap on, and mom has also put this cute little toy in there to hold them in a better position. And that really helps to elongate those tissues so that if they hit the stage that they need surgery, hopefully they'll need less. Did I hit everything? Once max correction is achieved, then we're going to split. All right, this is a child who came to us at about 4 weeks old. She had one leg that was hyperextended, and she had an extreme clubfoot on this side. This one was stuck in flexion, and she had clubfoot here, not as severe as the other side. After a few casts, this was her foot position, and this was that knee position after a few casts as well. I don't remember how many, and I should have put it on here, but I did not. And she was able to achieve full correction of knees and feet with casting and a tenotomy. That was all she needed. This is her at about, whoops. That she was maintaining. This is her, excuse me, slightly between 9 months and a year. So she was doing some independent standing and assisted standing. And just as a reference picture, that was her newborn picture.
5,
Muy
6,
bien.
7, 8, 9.
Okay. And then I'm going to play simultaneously her at the park. Now you'll see she's walking to her crocodile walker. I love this walker. Dayle will talk about it more on. And we're also, as long as they need to, and then to transition to walking independently. But if they don't, quite a while, it's okay, because every step they take is strengthening them. It's setting that reciprocal pattern in their body, because our kids don't always get to go through the normal developmental milestones. Many of them don't crawl. So we have to, like a child that's typically developing, they're going to have crawled for months before they walk. So they've got reciprocal patterning in their body. These kids don't always, and so we want them to get as many steps in as they can. All right.
I'm going to address some of the non and pre-surgical interventions that we do in OT and occupational therapy. Like we mentioned, we work on soft tissue preparation using moist heat, literally preparing the soft tissues, the muscles, the tendons, with using paraffin, myofascial release, to get ready for that passive range of motion. We also use manual techniques. Here you see one of our OTs, Mary, she applied paraffin, and then she's following it up with some passive stretching. And before, this kiddo was, fingers were completely tight, her thumb was indwelling, her wrist was flexed downwards. We did so much. We did casting, manual stretching, and the goal is always to maintain the correction after. So you see we do some paraffin, some stretching, some casting. With this little, we used a We used a plaster cast over fiberglass casting, and then we followed it up here with splinting. So to hold the correction that we did over a month and a half time, he had several casts, and then we followed it up with splinting. This kiddo, this hand was completely up towards his mouth, neglected the other side due to his torticollis, and now he has far more shoulder movement, and we're even starting to get some finger flexion and more movement in his fingers. I'm going to show this video really quickly, just to kind of eliminated position. So he's not working against gravity here, which we might do for strengthening, but here we want to just give him the option to be able to move his hand independently with a little bit of manual manipulation and manual guidance. Kinesio taped him before he went home on this date to kind of give that that prop for wrist flexion. So the progression, we want to start with a Just Right challenge. And I love the Just Right challenge because it really just means we're meeting the kids, and really anyone that we're seeing, we're meeting them where they are. So here we start with some palmar support, and we're doing weight bearing either on one side or both sides with a palmar support. We're supporting, you can see Mary is assisting her in side sit. And then as we progress, we're now going bilateral, both hands down with no palmar support. We have beautiful wrist flexion, beautiful fingers. And this is, she's getting some support of the trunk, but she's doing this a lot on her own. So we're strengthening for scapular mobility. We're doing shoulder strengthening. This is a really awesome position here. So here, the process. So like Fran mentioned, we provide passive range of motion, either with therapist guided passive range of motion. In this first picture here, you're seeing self range of motion. And we'll do that to kind of give our kiddos more control. You know, they don't always need to be stretched by us. He's able to do this on his own. And here you even see the other photo, a static progressive elbow flexion splint. So she could actually adjust this splint on her own to get more flexion as she wears it. And she wears it several hours throughout the day. And we'll see some more both of these cases as well. So here, I just love this, this case. So this patient are kiddos that have to travel to us. When her doctor actually told her that she would never move her hands, and you can see her here, she's independent, her adaptive crayons, and she's so proud of herself. Is our little that you saw a little bit earlier with the splints. This was him just a couple of months old, and this is him over here. We're working on extending the elbow. So his right hand was completely up to his mouth. His left hand was almost just behind him due to his torticollis and neglect, left-sided neglect. So with the cast, even though it's a little bit heavier, he's actually still able to get active shoulder movement, and we see some really awesome strengthening for the shoulders and the scapula as well, more scapular mobility. So for our intervention for the upper extremities, we always say trust the process. So whereas this little was told that she could never move her hands, we followed it with splinting, casting, and now she's able to move her hands. She's even working on feeding herself.
All right, so I want to take a little bit to talk about something that we're using that's new since we were here last year. I mentioned it last year, but we had not gone through the training yet. We are using now spinal electrical stimulation. We also now have Dr. Kevan Asadi. He is a neurosurgeon, and he is on our team now. What we discovered through a variety of time working with these patients, that many of these patients have a tethered cord. So we're doing MRIs on all of our kids with arthrogryposis and finding that indeed they do. Even if they didn't a little younger, sometimes it develops over time. And so Dr. Asadi is on board. He's on our team now. It's so wonderful. And he's doing the detethering. And then they're able to start therapy the next day. The only real contraindication is immersing in the water. So for 2 weeks until the incision is closed. So we are using detethering as needed. We're using spinal electrical stimulation, meaning the electrodes actually go over the spine, on the skin, but over the spine, and then the distal ones go wherever you're trying to affect at that moment. So to facilitate movement. So in this one right here, this is just examples of how we can use it to improve posture and trunk alignment. If I can find how to turn that back on, I'll go there. Okay, and this is just it's on, by the way. And it's off. First implementing. So you can see it's on right now. And in this one it's on, now it's off. And it's on, now it's off. Oh, no, now it's off. So it's very distinct when it comes on. When we test, I use a switch. Okay, so that's how I can tell exactly. This is the little boy, had the very big C curve. You'll see a picture of him in a moment. And he had the hand stuck by his face. Gigi has been doing a lot of work with him as well. We also use it with hands and lower extremities, but this is an example that was really, I thought, profound. Okay, so with the electrical stimulation, so prior to the day that I actually used spinal electrical stimulation on her, if I put something in her hands, you see it keeps falling. I have her picked up, but I'm not touching the switch yet. I was testing her that day to see which was going to help the most. So there it goes again. I'm not touching the switch. You can see both of my hands are there. So now I'm going to act like an octopus and get her set up, and I'm going to push the switch. And then you'll see my hands come away, and you'll see that now she's holding it. She's not dropping it. She's still holding it. And the second I let go, did you see her hand open and it drops again? So that was one of the key places that we wanted to set her home program. And grasp and release. And she's got the ability as far as physiologically it's there, the connections are there. So we want to now strengthen that, and that's pretty exciting to us. Okay. This is case study number 1 with spinal electrical stimulation. This is the little boy that you've been seeing throughout. This was his first day at our center. So he was stuck here. He was 9 months old, and he had been stuck here for months. And his family had actually picked up and moved to our center before they even met us, based on, ironically, the presentation that we've done for this conference in 2020 that is now out there on YouTube and people are seeing it. So I'm very grateful to you guys, because a lot of people have come to us because of that. And I will tell you, putting that together in the middle of a pandemic when you're actually still treating patients, it was overwhelming, but we got it done, and now it's out there, and we're still seeing kids from it. So anyhow, so he came to us stuck like that. We can see that he has arthrogryposis that are affecting all 4 limbs. He has severe torticollis, severe scoliosis, bilateral club foot, flexion, contracture of the knees, contractures of the upper extremities. Hips are stuck in that abduction, external rotation, and flexion. In this position, that child's not going to sit, right? He's been like that. It's not changed. He's now 9 months old. He's not going to sit independently if something doesn't happen. So our philosophy is unlock what you can unlock, see what you can get moving, and progress as if everything's going to happen just fine. Is it? I don't know. And I told the mom that. I don't know exactly where we're going to get. I don't know if he's going to be an independent sitter mover. I don't know. But I think we can make him better, more mobile than he is today. Because he would hardly be able to sit in a wheelchair like that. It would be very difficult to go through, the years like that. So anyhow, we started where we started. Oh, and one thing I wanted to mention, he had severe, painful constipation. So he would have a bowel movement every few days, and he would cry and bleed, and it was really awful. And after even just one day, getting hips moving, getting spine moving, she said he went home and he pooped the biggest one he ever had. So, even just look at the simple body functions, right? And then we started implementing the spinal electrical stimulation, and then we got them set up at home. She said that, his whole bowel routine changed, and he was able to uh, go through more like a normal child. I think he still has some regressions at times, but not the way he was. So this was the day that I implemented the spinal electrical stimulation for the first time on his upper extremities. And this is not in therapy. This is actually at home after that session. So, do I know exactly why he's able to do it afterwards? I don't know. Maybe he's more aware. I don't know. Maybe we learned a different way to position him. So in therapy, started using inside lying gravity eliminating. Would you please turn that on for me? I am a dinosaur. So so he was like, oh, I have something over here. I mean, that's life altering for that child. So and we've got the Atlantic test. And then once we got feet in position, then we went to practicing the knees into extension. Do I think he'll ever need surgery? No, I'm a realist, right? I think he's going to need surgery, but he's getting all this movement, all this strengthening, all this upright posture. And what does that also affect? It affects the heart, lungs. So, this is the first thing thought this thing ever. And I was doing a lot of motion for him, but that's okay. He's never stood. Do I expect him to take independent steps on day one? No, but that's not the point. The point is we're starting that reciprocal pattern. And I will tell you, within a couple weeks, that child was initiating steps. He's still going to need some surgery, but it's okay to start where you start, and and he loved it. So this is also very helpful video. So he had.
Okay, yeah, let's go over this way, and when it comes back on, you are
Here,
gonna fix
but
it.
he has quite a big curve. And I'm so sorry, I'm running late. Okay, so anyhow, this is my last one.
Let's go.
So he is contracting on his side where he has the convexity, and he is
Good job,
correcting.
buddy.
Sitting up.
Good
That was
job,
the first
you
time we've ever
did
seen that.
it.
We've got both of the electrodes there. Now I'm going to be quiet. I think that's speak over there. Please, I'm just going to tell you that case study number 2, we used it on his abdominal muscles, and he was able to come up. I'll do one, and then I'm moving on. Using abdominal muscles with the first time the electrical stimulation on the triceps to get him to do the quadruped. Okay?
So I just wanted to go over a couple of the pre and post surgical interventions that we do for upper extremities. Here you see a patient that's being casted before a tendon transfer with the goal of wrist extension. So for about 2 weeks, we do wrist extension. We try to bring the child who's typically 30 to sometimes even more flexed, and we try to get them up to neutral. Then we're working on getting them up to wrist extension, 15 to 20 degrees wrist extension. Here we even added some kinesio tape to work on the fingers and get those fingers that were in an ulnar drift, kind of like drifted to his pinky side, and we're bringing them into neutral alignment. During this time, we change the cast every 3 to 5 days. We don't want to leave them in the cast too long. And in OT, we try to even do it less than 5 days. It's normally 3 days in between every cast. And we're also going to work on fine motor and working on our digits. That's where you see the little sensory bin here. This is one of my kiddos, and I love to show this case because she's not a kiddo, she's 22. And she came to us for a soft tissue elbow release as well as an FCU transfer. Here, she had undergone, in the first image, she's undergone her FCU transfer, which is that tendon transfer I was referring to. And in this second photo, she's just got done doing some paraffin, and you could even see where she was flexed prior. You could see that she's getting some more passive wrist extension as she's pushing into the paraffin. Here's just a short little clip of one of the exercises. She doesn't need a gym membership. Look. Extension, active, as well as wrist. This is after her soft tissue elbow release. She stuck an extension, and she actually had just a very shallow arc of motion, less than 15 degrees. All right, so this case is a patient of ours that had undergone surgery in Poland when she was younger. She came to us at 16. One of her upper extremities was surgically fixed to extension, and the other was surgically fixed into flexion, and it was no longer serving. It was a kind of an idea that they had to get her to be functional, to do the things that they thought were important, but she thought putting on mascara was important. So she came to us and she got a soft tissue elbow release, and we started working on some passive range of motion, weight bearing, which is key. We could start doing this about a week after their elbow release, and you know, she's doing this self range of motion to kind of blow some bubbles, which is like my favorite activity ever. Okay, so this is one of our kiddos. He's doing some self range of motion after a soft tissue elbow release. I think that giving patients the ability to do their own range of motion gets that control. They get that control back, less anxiety, and he could do this on his own. We're practicing what he's going to be doing at home as he, when he returns. And here he's just doing some active range of motion. I think that we were doing like a really cool caterpillar. I mean, I think it was cool. Okay, so this is how we grade up. So she has, this was after her elbow release, after her FCU transfer, and now we're working on both, right? So we're working elbow and her wrist to pick things up, flex, drop them in the cup. And so she's controlling this on her own. She gets to see when it is going on and off. And this is her, something that she really honestly never thought she'd be able to do. She's flexing her elbow against gravity. And this was a really powerful day for us all. So happy. So rehab following our humeral derotations. She's told me every single day since her humeral derotation, which was less than 2 months ago, something new that she could do every single day. So this was her just a couple days post-op. We did paraffin in order to get her splints back on, and we did lots of passive range of motion. We're working on external range of motion for the shoulders, flexion as well, and she's basically doing the same independently, being able to paint on this slanted surface here. I'm just going to show you this really quick video. This was her just after she was able to go back into the pool following her humeral derotations. For the first time ever, she was able to dive and collect a shark from the bottom of the pool, something that she could never do before. And I just want to show you how she can lift this light snack, but she always had a fear of dropping things. So here you could just see.
Go ahead, Jada.
Just a couple weeks after.
What you doing?
And you could see as she walks and she's telling you what she's doing, she's carrying her snack over to the table. And you can even hear her mom. She says, Mom, I don't think I could get this on the table. Could you help me? And her mom really encourages her to do it on her own, and as you'll
Is
see
that your
shortly,
watch?
success.
I think you can do it. Can you try?
She could do it, and
Good work, Jada.
success. Really, really amazing.
Hey, Jada.
Yeah, and she's so proud, and this is why we do it.
All right, so despite early intervention, oftentimes children still require surgery, and that's what I'm going to talk to you now. We all work with Dr. Feldman at the Paley Institute, and we see a lot of children with arthrogryposis, and this is one of my favorite little friends named Magnolia, and her mom and dad and Noli are watching. Hi! This is Magnolia's newborn picture, and you can see, like most people will tell you, this is the worst that they'll ever look in their whole lives. And Magnolia came to our center when she was about 4 months old and went through early intervention. And what happens mostly is the families travel back and forth. This family's from Illinois. They would come down and stay with us for 3 to 4 weeks at a time. We would give them some really intensive therapy, physical therapy and occupational therapy 5 days a week, teach them things to incorporate into the day. When they're at home, they would go home and practice these things, and when they're ready for their next round of physical therapy intensives, they would come back and see us. So post-operative care, Dr. Feldman is presenting tomorrow at 10 o'clock, and he'll be going more deeply into the surgeries he performs, but mostly there's bony correction, osteotomies, soft tissue releases, and nerve decompressions. The big surgeries for correction of hip and knee flexion and contractures usually require hospitalization for 2 to 5 nights, and that's really for pain control and a monitor for any complications. They start daily physical therapy on the first day that they get out of the hospital. We always recommend that they stay for a minimum of 6 weeks. You'll see in this first picture, this is Magnolia after she had the first side operated on. They will leave the hospital in these knee immobilizers, and we encourage them to wear their AFO with the knee immobilizer to really help control the position of the foot. And then you can see that's a very good example of a before and an after, as both her legs looked like this. And when she left the hospital, she had 2 knee immobilizers on, and often the kids come in wagons, so it keeps their legs supported in their newly achieved position. So physical therapy, the goals for the first 4 weeks is range of motion, teaching the parents the stretches that are required. We need the stretches to be done 3 times a day. 1 time a day is usually with us in therapy, and the other 2 times it's for the parents. So we make videos, we make pictures, we have the parents perform all of these stretches with hand over hand. It's also super important to develop rapport with the children. They're oftentimes mostly afraid and fearful more than they are in pain. So this is Magnolia. This is a couple weeks after surgery on her second side, so she's had both legs corrected, but you can see the position of her legs. They want to go back into the position that they came from. There's a very high incidence of regression. You can see she's in an abducted, externally rotated position, and this is just when she had like an hour's break from her braces. In therapy, we're also working on putting those hips into neutral alignment when we're performing all of the stretches, because that's really important that they want to go back to that position that they came from. Even though she came from a really flexed position, we want to maintain that. So you can see in that first picture, we're doing her knee bending on her belly. And even though she came from a very flexed position, this is still something that we want to make sure that we maintain. So now we've got them in this beautifully straightened position, but we also don't want them to lose the ability to bend their knee. The next picture is me and Magnolia in therapy, and a lot of time these kids don't even realize that those legs that have served them no purpose are even attached to their bodies. So in this particular case, I was putting bells on her feet and ringing the bells to get her to even notice that these legs were actually attached to her and could be of some use to her. We used electrical stimulation with Magnolia, trying to get her to initiate active motion. So then the goals for the first 4 weeks is increasing hip motion 0 to 90 degrees, increasing knee motion 0 to 90 degrees, trying to initiate active mobility through NMES and spinal electrical stim, and the child will be casted for custom-made prosthetics and orthotics. We have our own in-house prosthetics and orthotics department, and it's super duper duper important that you have very good bracing that will help to maintain this new position. So let's talk about braces. I cannot express enough how important these braces are. This is a 23-hour-a-day commitment that these children remain in these braces. Now, a couple of things that we have done to make it a little more manageable for the child and the patients is we have a removable hip band. And that's something that I don't think is being done many places. But if you remove the hip band, it's these red screws that they've made, then the children at nighttime can sleep. They can roll, they can move onto their sides easier rather than being stiff as a board with the hip band on. However, the hip band is super important because without the hip band, their legs will be out in this position that they came from. So the hip band is what keeps them in neutral alignment and keeps their hips in the right position. So the goals of the brace are to help maintain good neutral alignment, the knees are straight, and we're preparing them to stand oftentimes for the first time in their lives. So the goals of physical therapy from weeks 4 and on is as soon as they are cleared for weight bearing, which is typically 4 weeks from the surgery, they're allowed to start standing in long leg braces with the knees locked. We encourage they must wear the braces with their knees locked when they initiate standing because they don't have the quad strength back, even if they had quad strength to start with, until a little bit later after they recover from surgery. We are still encouraging active movement, working on standing balance, working on standing posture. We're sidestepping, cruising, doing other balance activities. I like having them stand with their back against the wall to kind of give them posterior support. You'll see a lot of people with arthrogryposis are flexed at their hips, and oftentimes that is due to weakness in the glutes. So it's a twofold problem. They've got tightness in the front of their hips and weakness in their glute muscles. The light gait, I can't say enough about the light gait. If you can get your child to a facility with a light gait, I strongly recommend it if your child is learning to walk and stand for the first time. And then we start to decide which walker and gait trainer is most appropriate. Here is a, there we go. Using the light gait. They love the light gait. I mean, they're afraid of it at first when you say, okay, it's time to put on your blue jacket, we're gonna go walking. And I think the biggest reason they love it is they feel safe and they feel supported. And this is time for them to watch a little Mickey Mouse Playhouse or, one of Bluey or something, because I am providing the motion for them. I am giving them the weight shifting and the advancing of their legs because this is new to them. So by me providing them with this action, this is motor learning. This is training their brains. This is giving them what they don't have. And I've had kids where I put them on the light gate for the first day and their legs are dragging behind them and they have no idea that anything is supposed to be happening. And the longer we do it and the more we do it, they start initiating that movement for themselves. And actually, I found out today that Magnolia's family literally bought a light gate online through another family and just bought one for their home use. So that's super exciting.
Child no longer need it.
Yes. I also use the light gate, not just on the treadmill. I also use it on the ground. Magnolia. And we're trying to get her to initiate some active movement. Again, trying to recognize that there is cause and effect, that if she moves her foot, that she is going to be able to move that ball. And using her parents as motivation, or oftentimes snacks. Snacks work. Okay, how to pick the right gait trainer or walker. There's lots of walkers out there. I would say far and away our favorite walker for children learning to walk for the first time is the crocodile walker. And the reason I like the crocodile so much is that the upper extremity adjustments can be so custom for so many unique upper extremities that are often associated with arthrogryposis. So you can move them in or out, wave them in, wave them out. And the other thing I love about this walker is the Riften sling. So this is the sling from the Riften walker that I have under them attached to their walker, and it's literally going to unweight them, almost like the light gate is, to make it easier for them to advance their legs. So I love this walker. We do use the Riften Pacer sometimes, but I find that it's very square and more stable and not as mobile. Don't forget to work on their functional mobility, because that's getting them to scoot on their bottom, having to make sure that they're still able to get up from the floor. This little girl has absolutely no active movement in her upper extremities, but she's still able to get herself up from the floor into a sitting position.
And this was after surgery. I'm completely confident that she'll be able to do that again.
Yep.
I think she probably is there right now.
Yep. My next one, this is Elise, and Elise was stuck in extension. This little girl came to our center when she was about 3 months old. The family relocated from Texas. The mother is actually a pediatric physical therapist herself and is now working for us, which is kind of fun. So this is Elise going through all of the early intervention. This was her. That was the most movement that she had in her arms and her legs. Real casting. She never required a tenotomy. We're working on sit to stand. This is Elise after she did have surgical intervention, and all that Dr. Feldman decided to do with Elise was soft tissue release. He released her rectus, and what this allowed was to increase knee flexion. So Elise, like I said before, was more stuck in extension. She didn't have more than about 40 to 50 degrees of flexion. After this soft tissue release and after several weeks of physical therapy, she's at 0 to 90 degrees on both sides. These braces, these long leg braces, do have the removable hip band. They also have another feature on the back. I don't know if you can see, there's a strap. So you can pull them into flexion using this strap and hold them in this flexed position as a long, prolonged stretch. So some nights she sleeps flexed and some nights she was sleeping extended. Elise did always have active quads. Actually, her quads muscles were super overreactive. That would hold her in extension. So she was able to progress from these long leg braces to short braces. But in general, progressing from long leg braces to short braces, this is something that's really, really important to me. And that's because some kids with arthrogryposis do not have a quadricep muscle. So long leg braces is your goal. That is your end goal, to get them independent with long leg braces with or without an assistive device. If I'm always working to progress them to that next level. So if they've mastered and they're standing and they're walking with their knees extended, I'm going to be working from early on with the knees unlocked to try and activate those quad muscles. I want to progress every child that I have as much as they can, and we're constantly pushing that envelope. So it's not like we get to one place and then we stop. We're still moving. When their muscles are strong enough to support themselves in standing with their braces unlocked, it's probably a good time to start trying to transition into short braces or AFOs. Okay, this is Elise after surgery.
Okay, I'm sorry, ready?
She's in her short AFO braces, and we're working on sit to stand. So even though her passive motion is 0 to 90, her active motion isn't there yet. She's lacking that terminal knee extension, the last little bit of full straightening, and she's also lacking that the last bit of her knee flexion actively. So these are still things we're working on, but she's now walking independently. Transitions, lots, just because your child can sit independently, can they get into sitting independently? All this little girl wants to do is be up and walking. Now that she's taken her first step, she is on Oh, she is on the go. Oh, this one I don't think loaded. But anyway, we're working on getting up from the floor. And so we're using her upper extremities, and we're using a 4-inch bench for her to put her arms on and use her arms to walk herself up into a stand position. Okay, this is baby Elise and her walking. I'm gonna just, I don't know, the rest of my videos might not play. Okay, this is baby Lydia. This is a 2-second. We're just gonna go through. This is Lydia. We had pointed her out earlier. She had a complete C curve in her spine, torticollis, all extremities involved. She went through early intervention at our center, traveling back and forth from Utah. This is her after she required hip and knee corrective surgery with Dr. Feldman. The other side was corrected all through physical therapy and serial casting and serial splinting and bracing. This is Lydia. She had progressed down to AFOs. She has good quad strength. You can see she's crouched, and we're definitely still working on improving that, which she continues to do so. This is her walking with the shopping cart. This shopping cart is made by Melissa and Doug, and we love it because you can weight it. This is Lydia at a regular, typical gymnastics class. You can see she's much more flexible than the little boy in the class with her. This is, let's see if this one will play. This is Lydia at the grocery store. This is Lydia at the grocery store. And it shows her bending down, right? So great control of her balance, picking up these muffins, and she literally lifts them up over her head and places them in the shopping basket. So the amount of active shoulder flexion when all she had was flickers of movement in her upper extremities was really impressive. This one doesn't play. This is Lydia on vacation with her family doing these entire, I can't even remember how many steps, up the steps independently. I can't believe they're not playing.
Not even holding onto the wall.
Nope.
I mean, it blew us all away.
This is Lydia jumping. If the video would play, it's not. It's telling me I'm over time, I guess.
I bet you saying get off the stage, we've cut you off.
All right, one more, the last one. So that was Lydia jumping off of there, and then the last one is Lydia jumping on the trampoline, which we loved. And my last thing to say is that I am blessed every single day because I work at the Paley Institute where we make the impossible possible. And my message to you is to trust your gut. If you are at a place where your therapist or your doctor is telling you that there's nothing that they can do to help your child, it's time to find a new place, because always trust your gut.